Hello everyone, this session we will be discussing about diseases of retina. It's a very big chapter. There are a lot of important topics in this chapter and they are all frequently asked in exams also. We'll be briefly discussing about the major ones. To start with, a small session on the anatomy, a few things that we should know in case of retina. So to start with, it is the innermost tunic of the eyeball. So we know that when you recollect the structure of the eyeball is actually a rounded globe-like structure, and when you see the innermost structure, the most neurosensitive area of the eyeball, which is the innermost area, is mainly constituted by the retina. Now it's a very thin, delicate, transparent membrane. So it is a last membrane there, and it is a very thin, delicate, transparent membrane and the most highly developed tissue in the eye. Because we know any kind of light impulses, whatever we get received in our eyes is being received in the retina, and then from there it goes through the optic nerve to the central nervous system. So it is the most highly developed tissue of the eye. You will understand why when I tell you about the details of the anatomy of retina. Normally, it is purplish red in color, and it extends from the optic disc area to the ora serrata. So that is the extension of retina. From the optic disc to the ora serrata, you have the thin transparent membrane which is highly developed tissue of the eye, that is a retina. Now, if you see retina in detail, you can see that there are two distinct areas in the retina. There is a small posterior pole and a peripheral retina. There is one pole at the posterior end and peripheral retina, which is surrounding the innermost area of the eyeball. Now, between the posterior pole as well as the peripheral retina, there is a small space which is called by the name retinal equator. So, in brief anatomy, it is the innermost tunic of the eyeball, which is very thin, delicate and a transparent membrane and very highly developed tissue of the eyeball, purplish red in color. Optic disc to ora serrata is the area where there is extension of the retina, and it has two distinct areas, being a posterior pole as well as the peripheral retina. In between these two, there is a small area of a retinal equator. Now, what are these terms? We have been telling posterior pole, optic disc, macula lutea. Let us have an idea about what these terms actually mean. So, posterior pole is the first word. This is the area of retina which is posterior to the retinal equator. So, when you see the middle area, behind that you can see in the middle of the area we have the retinal equator. So, posterior to the retinal equator we have an area of the retina which is called by the name the posterior pole, that is the center portion. Now, optic disc. Optic disc is actually understood only if you know what the optic nerve is. So, if we know that the optic nerve leaves at one point from the retina towards the central nervous system, that area where the optic nerve begins, in the retina. For example, if you see the retina like this, so here through this area the optic nerve leaves. So, at this area where the optic nerve starts, that beginning of the optic nerve is called by the name optic nerve head. So, optic nerve head is actually the beginning of the optic nerve. It is a pink colored, very well defined oval area. And now, in that area where the optic nerve actually starts, that is the optic disc, at the center there is a small depression. There is a depression in the optic disc, and this depression is called by the name physiological cup. There is a depression in the optic disc called by the name physiological cup. Now, central retinal arteries and vein emerge through this cup. Now, what is the purpose of this physiological cup there? It is through this cup, at that point of this cup is where the central retinal artery as well as the central retinal vein is going to emerge, the point from which these two vessels are emerging. Now, another important thing that you have to note here is there are no photoreceptors in this area, in a particular area. That is, absolute scotoma in visual field is present, and that is called by the name blind spot. That is a physiological blind spot. So, here there is absent photoreceptors, that is in that area, when you see the visual field, at that point there will be absolute scotoma, and this area is called by the name physiological blind spot. Now, What is macula lutea? So macula lutea is yellow in color, and it's actually a yellowish spot to be precise, and it is darker compared to the surrounding areas. And at the central, in the there is a small macula lutea, and at the center of the macula lutea there is one more depression. So there is a centrally depressed part of the macula, and this is called by the name fovea centralis. Now fovea centralis is one of the most sensitive part of the retina asset. So it is the most sensitive part of the retina, and in the fovea centralis there is a small shining pit which is called by the name foveola. So the shining pit seen in the fovea centralis is called by the name foveola. Now the next word that you should be knowing is the peripheral retina. So I told you there is a retinal equator. So by the retinal equator, that area, an area will be bounded by the retinal equator posteriorly, and it is anteriorly bounded by the ora serrata. So it is that area of the retina where in front you have the ora serrata and behind you have the retinal equator. So that area bounded posteriorly by the retinal equator and anteriorly by the ora serrata. So there is one area where that area's posterior part is at the back of it is what we call by the name retinal equator, and in the front it is called by the name ora serrata. So anteriorly it is bound by ora serrata and posteriorly bound by the name retinal equator. Now what is this ora serrata? Ora serrata is nothing. It is a serrated peripheral margin where the retina ends. So it is morphologically it is serrated area, and it is at the periphery, towards the peripheral margin it is present, and this is the area where retina ends anteriorly, and retina is attached to the vitreous as well as the choroid at this area, at the area of ora serrata. So the retina will be attached to the vitreous as well as the choroid at the area of ora serrata. Now these are the terms to recollect again. There is a posterior pole, that area of the retina which is posterior to the equator, the central portion, and from the equator, that from the retinal equator to the ora serrata is what the retina extends. Now optic disc, it's actually the optic nerve head, that is basically the optic nerve begins at this point. It is a pink colored, very well defined area. There is a depression in that area. It is called by the name physiological cup. This is the area where the central retinal artery as well as the vein emerge through this cup. And the photoreceptors are absent here, which will lead absolute scotoma in the visual field, and physiologically it is called by the name, like physiological blind spot is the name what we give. And macula lutea is an yellowish spot, which is the next one. It is darker in color, and there is a small central depression in the area of macula which is called by the name fovea centralis, which is the most sensitive part of the retina, and there is a small shining pit present in the fovea centralis which is called by the name foveola. Now the next word is peripheral retina, that area of the retina which is bounded by anteriorly the ora serrata and posteriorly the retinal equator. And again the retina, when the end point of the retina where there are serrated peripheral margins, that is called by the name ora serrata, and at this area the retina is attached to the vitreous as well as the choroid. So these are the important terms that you have just to get an idea, because these terms will be repeatedly coming over the discussion. So just to get an idea what each is about. Now about the microscopic structure. So when you see retina under microscope, there are 10 different layers of retina. There are 10 different layers. Now these 10 different layers are basically arranged in 2 different segments, that is a pigment epithelium, and the remaining part comes under the neurosensory retina. So the first part, that is the epithelium, is the pigment epithelium, and the all other parts are called by the name neurosensory retina. Now let us see what are the 10 different parts, the 10 different layers under microscopic examination. The first one is a pigment epithelium. So the outermost, the topmost layer is the epithelium, which is the pigment epithelium, and it is a single layer of cells. You can see here it will be a single layer of cells like this, and it contains pigments, that is why the name is pigment epithelium, and it is strongly adhered to the choroid. Adherence to choroid is present. The main purpose of this layer is to provide metabolic support to the neurosensory retina. So we need the neurosensory retina for normal vision status. So this neurosensory retina metabolic support and all is provided by this pigment epithelium. So that is the first one, outermost layer, a single layer of cells containing pigments which is adhered to the choroid, and the metabolic support for the neurosensory retina is provided by the pigment epithelium. The next layer is an interphotoreceptor matrix. Now, interphotoreceptor matrix is actually a potential space between the pigment epithelium and the neurosensory area. We know that there is two important areas, the pigment epithelium and the neurosensory retina. Between these two there is a small space, a potential space which is called by the name interphotoreceptor matrix. Now, what is the purpose here? The retinal attachment, the adhesions, the molecular trafficking, the facilitation of phagocytosis, all this happens in between this space. This interphotoreceptor matrix space is the main area or the main arena where retinal attachment, adhesions, molecular trafficking and phagocytosis, all these things happen. So that is one small area. This is not a part of the retinal layer as such, but just understand there is a small area, potential space between these two areas. Now coming to the second layer, which is the layer of rods and cones. Here you can see there are multiple cells, rods and cones are present. They are actually photoreceptors. Rods have rhodopsin in them and it is helping for the scotopic vision. Cones, they have another pigment available in them and they are helping for the photopic vision. So rods and cones is in the second layer, a layer of rods and cones which are photoreceptors. Rods produce rhodopsin and they contain rhodopsin and it is helping for scotopic vision. Cones help for photopic vision. So you can see here the different types of cell. This layer is the layer of rods and cones. Now the second layer is, the third layer is external limiting membrane. So here you can see one yellow colored layer here, which is marked, see, you can see as green color now. That is the next layer, which is the external limiting membrane. Now it is actually a fenestrated membrane. There are small holes, there are small gaps in it. It's a fenestrated membrane. Now what is the purpose of this fenestration is that the rods and cones which was present in the above layer, they have small processes, tiny lengthy processes arising from them. These processes of the rods and cones are passing through these fenestrations downward. So external limiting membrane is a fenestrated membrane through which the processes of rods and cones are going to ascend down or pass down. Now after the external limiting membrane you have the outer nuclear layer. Now this layer is the outer nuclear layer. So outer nuclear layer generally contains nuclei of the rods and cones. The name itself says there is nuclei of the rods and cones in the outer nuclear layer. You can see the nuclei present here, one nuclei, here one nuclei, here one nuclei. Nuclei of the rods and cones will be present there. The next one is the outer plexiform layer. Now what is this outer plexiform layer? Outer plexiform layers, they have dendrites of bipolar cells and horizontal cells. Here you have the cone pedicles as well as the rod spherules. So when you see the rod, they have the rods, we have rods as well as the cones in that area. In the rods, they will have spherules, spherical shaped structures, and cones will have pedicle, long pedicles will be there. This will be joined to the dendrites of the bipolar cells and horizontal cells in the layer of plexiform layer. So there will be a joining. You can see here in this layer, the spherules as well as pedicles, they are joining the dendrites. These are the dendrites of the bipolar cells and the horizontal cells. That is what the outer plexiform layer is about. The next one is inner nuclear layer. So that is the next layer, which is inner nuclear layer. Here I already told you it is meeting up with the bipolar cells as well as the horizontal cells in the plexiform layer. Now, what happens to the cell bodies of these bipolar cells, these horizontal cells and all? Yes, the cell bodies of these cells, the bipolar cells, the horizontal cells, the amacrine cells or the Muller cells, all the cell bodies are present in the inner nuclear layer. You can see there are multiple cell bodies. These are amacrine cells, these are bipolar cells where the cell bodies will be present. Now, these cell bodies are seen in the inner nuclear layer. Now, coming to the next layer, which is inner plexiform layer. So, inner plexiform layer, what happens is there is a connection. So, we have bipolar cells, we have dendrites, all the cells were there, no, in one layer before. All the cells, they have axons connecting downwards. This axons will be connected with the processes, with the axons of the other cells, that is connections between the axons of bipolar cells and dendrites of ganglion cells, processes of amacrine cells. So, here you can see in the inner plexiform layer, you can see there are interconnections. See, they are connected to the axons of bipolar cells, dendrites, ganglion cells, different connections will be there in the inner plexiform layer. Now, the next layer is the ganglion cell layer. Of course, ganglion cell layer means that layer which contains the cell bodies of the ganglion cells. You can see here in green color, these are the ganglion cell bodies, they will be present in the ganglion cell layer. And finally, the last one is a nerve fiber layer, that is from these ganglion cells the nerve fibers arise outside like this. So, it is the layer of all the nerve fibers. The axons of the ganglion cells, they form together, they merge together to form the optic nerve. So, from here onwards it is the optic nerve that moves outside. And finally, there is a small membrane at the end of this which is called by the name an internal limiting membrane, which is the innermost layer, and it is going to separate the retina from the vitreous. It is really confusing to understand what each layer is and all, but it is equally important that you should know this. So, 10 layers is very important. So, always remember the first one is a pigment epithelium. The pigment epithelium just consists one single layer. Any cells, the first layer is going to be an epithelium. So, the pigment epithelium, remember retina, there are a lot of pigmented structures and all. So, pigment epithelium is the first cell layer. The next layer, there is a small matrix, a photoreceptor matrix is there, but that is not a part of the 10 layers of retina, but just know there is a small matrix. Then comes the neurosensory area. In the neurosensory area, of course, the first thing that should receive light should be rods and cones. Now, those rods and cones will be present in the second layer, which is the layer of rod and cone. Now, this rods and cones will be limited by a membrane which is externally outside, that is external limiting membrane. Now, why is that membrane there? So that all the rods and cones, the processes can move outside. So, once the processes come, the next thing is the nucleus. The nucleus should be there. So, the rods and cones nucleus will be present in the outer nuclear layer. Now, the nucleus is over, it is coming and meeting with the dendrites of the bipolar cells. So, there it is the plexiform cells. When they meet or when they mix, it is called plexiform layer. So, outer plexiform layer. All these are external or outer, the first three. There is an external limiting membrane, outer nuclear layer and outer plexiform layer. So, these are the outside structures. Now, we are starting with the inner structure. So, soon after the outer plexiform layer, we have the inner nuclear layer. Why again inner nuclear layer? Because again the nucleus of these bipolar cells, dendrite cells, the cell bodies are actually present in this layer. After that again connection comes. Whenever there is a connection or meeting up of different cell bodies, then it is called by the name plexiform. So, plexiform always means there is a connection. So, it is the inner layer of connection. So, inner plexiform layer where there are connections between the axons of the bipolar cells, dendrites of ganglion cells and other processes of amacrine cells. Now, after all this again we need the cell body, but here the cell body has a different name, that is the ganglion cell layer we call it. It is very important, here there are multiple ganglions. So, ganglion cell layer is the next layer, and of course from all the ganglions what is going to arise? The nerve fibers are going to arise. So, all the nerve fibers together will form the next layer, that is the 9th layer, which is the nerve fiber layer. Now, to seal everything intact, there is an internal limiting membrane, that is to separate the retina from the vitreous. There is a small membrane, limiting membrane, which is internal limiting membrane. I hope you got an idea about the 10 different layers. At least the names you should be able to recollect. So, after the 10 layers, the anatomy is over. So, a brief discussion of anatomy was starting from how retina looks, what are the important terms that you should be knowing in case of this, and the microscopic structure. See, I have splitted the diagrams into different layers so that you get an idea about how this looks. But when you draw it in your exam, all this should be one after the other like a sandwich. So, that is very important. So, here you have to actually place the epithelium, pigment epithelium like this, and then below this should come this layer, below this layer, like that, one after the other you have to draw it in a single diagram. This is just for understanding purpose, I have split it into different parts. Now, coming to the major disease conditions in case of retina. So, the first thing is to study about the retinal vessels. Any kind of pathologies in the retina associated with problems with the retinal vessels. So, the main retinal vessels that we are talking about here is the retinal vein and the retinal artery. So, basically the retinal vein or retinal artery can get occluded at any time. So, occlusions of the retinal vessels, retinal vessel occlusions is what we are talking about. Now, a brief start at the beginning, I will just brief you about some important things which is a general thing to be known. This artery as well as vein, they can get occluded from the main branch, from the central branch itself, or from the branch as such, branch of the central vessel as such. So, it is classified as a central retinal artery or vein occlusion or a branch of that getting occluded. So, our question wise, when we look into the most important topics, central retinal vein and central retinal artery occlusions are important. So, we will discuss, we'll just discuss about those two topics which is very important for our exams. So, central retinal artery occlusion. So, central retinal artery occlusion etiology, the first thing, basically it is an artery that gets occluded. So, how is an artery going to get occluded? There should be some emboli coming there. Now, most of the time this, in case of central retinal artery occlusion, the emboli usually comes from the carotid artery or the cardiac area, that is from the heart. So, the emboli is there, and this emboli, from where is it coming? It is either from the carotid artery as such or from the cardiac origin, any atrial fibrillation or any other tachycardias associated emboli formation. So, emboli from carotid arteries or cardiac origin is the most important etiology associated with central retinal artery occlusion. Now, what type of emboli are we talking about? So, most of the times a cardiac emboli or a carotid artery emboli are cholesterol emboli, calcium emboli or platelet fibrin emboli. So, cholesterol emboli most of the times it is related, like it is usually related with atheromatous changes. So, atheromas in the carotid artery is one reason, and it's usually orange in color. Now, calcium emboli is usually from a cardiac vessel and it usually is white in color. Now, platelet fibrin emboli, usually a dull white color, it is also going to arise from an atheroma only, but from the carotid. And this is responsible for retinal ischemic attacks. There can be retinal ischemic attacks in these patients. So, emboli from a carotid artery or a cardiac origin, cholesterol emboli can be there, calcium emboli can be there, platelet fibrin emboli can be there. Now, apart from this, there can be atheromatous changes related to thrombosis, that is basically in the lamina cribrosa layer. Now, the lamina cribrosa is actually a structure which is present, a bony structure where there are multiple holes present. The nerve fibers are going to pass through this lamina cribrosa and go out of the optic area. So, atherosis related thrombosis mainly occurs in the lamina cribrosa. Then there are retinal arteritis. There can be inflammation in the retinal artery with obliteration. So, retinal arteritis is also one important cause of occlusion. Then there can be angiospasm, intraocular pressure increasing can be one important reason. Any other thrombophilic disorders, already patient has a coagulopathy, undergoing coagulopathy in that cases, or certain other conditions like use of OCPs or a polycythemia existing in the patient, or an antiphospholipid syndrome, or any kind of sickling hemoglobinopathies are also important causes. So, always remember it is an arterial occlusion. Arterial occlusion most of the times is going to be an emboli, and this emboli usually from the heart or from the carotid. Atherosis related thrombosis is the second cause, which is mainly in the lamina cribrosa area. Retinal arteritis with obliteration, angiospasm, raised intraocular pressure, thrombophilic disorders existing in the patient or other sickling hemoglobinopathies, antiphospholipid syndrome, then polycythemia and OCP use. These are the common etiologies associated with central retinal artery occlusion. Now, coming to the clinical features. So, if you see here, always remember one important thing. This should be a motto always in your head. Whenever there is a patient who comes with a sudden loss of vision and it is not associated with any pain. A painless sudden loss of vision, always think about central retinal artery occlusion. So, a sudden loss of vision which is not associated with pain. Within seconds, there is complete loss of vision in these patients. And if you take a detailed history, you will get to know that the patient had a history of, in the past, patient had a history of transient visual loss. Episodes of transient visual loss was there in the past, which is mainly called by the name amaurosis fugax. Now, these are the important symptoms as such. Apart from this, there are no other presenting features. If you see the signs of these patients, the visual acuity of these patients is going to be reduced. That is the first important sign. Then if you check for the pupillary reflex, the direct pupillary reflex is usually absent, but rapid afferent pupillary defect is going to be present. So, RAPD positive. So, direct pupillary reflex is absent, RAPD is present. Now, coming to the fundus examination. This is where you can find a lot of signs as such, because it is about the retina. So, retina will show maximum changes because of the occlusion of the central retinal artery. So, the first thing is there is going to be ischemia in that area. So, think in that sense and then evaluate the fundus examination. So, obvious narrowing of the retinal vessels is going to be there. So, narrowing of the retinal vessels is the first thing, because it is going to be an occlusion, right? The arteries are getting occluded. So, there will be narrowing of the vessels. Now, if you see the arteries and veins, the narrowing of the arteries is much more than that of the veins, because it is a central retinal artery occlusion. So, narrowing of the retinal vessels where arteries are more narrowed than that of veins. The next thing is there is ischemia, and following ischemia there will be edema. So, whenever there is a endothelial injury, the first thing, the three important things that happens there is hemostasis. To establish hemostasis, the first thing is increased permeability. There can be stasis of the blood as such, and there can be certain endothelial changes. So, here because of the increased permeability, there is ischemic edema occurring. So, because of the ischemic edema, the color changes into a milky white appearance. So, a milky white appearance due to ischemic edema. Now, there you can see the only thing vascular there is the choroid. There will be a small area which is vascular, and that will be the choroid. Because of the vascular choroid present there, a cherry red spot is seen in this milky white area. So, a cherry red spot present in this fundus examination is usually the vascular choroid that you can see there. Then you can see a typical cattle trucking. Now, what is this cattle trucking is? There is segmentation of blood column in the retinal vein. See, there is no passage of blood through the arteries. In the vein, whatever blood is present, you can see as small segments. So, segmentation of blood column will be present in the retinal vein, and it looks like a cattle trucking. So, that is another important finding. Then the atrophy of the arteries, the retina as such undergoes atrophy, or the optic disc as such will undergo atrophy because of the reduced blood supply. So, fundus examination shows maximum changes starting with the narrowing of the vessels where arteries are more narrowed than that of veins, milky white appearance due to the edema, cherry red spot because of the vascular choroid, cattle trucking because of the segmentation of the blood column in the retinal veins, and atrophy of the arteries, the retina, or even the optic disc. Now, if you do an imaging of this fundus, the retina as such, you can see that it is done with OCT, optical coherence tomography. Here there is hyperreflectivity with thick inferior retina. So, there is hyperreflectivity in that area, and there will be a very thick retina in the inferior part. The thickness of the inferior retina will be more. Apart from that, you can look autofluorescence imaging. In autofluorescence imaging, the retina will be seen as a diminished surface, and FFA will show delayed arterial filling. So, fundus fluorescence angiography will show delayed arterial filling. So, when you correlate it with central retinal artery occlusion, it is easy to understand. The visual acuity because of sudden loss of vision is going to be decreased. The next thing is the direct pupillary reflex. The direct pupillary reflex will be absent, and RAPD will be present. A fundus examination will be showing the narrowing of the vessels, milky white appearance due to ischemic edema, the cherry red spot which will show the vascular choroid, and there will be a small cattle trucking which is seen there, which is because of the segmentation of the blood column in the retinal veins. and atrophy of the structures there. Fundus imaging, the OCT shows hyperreflectivity with thick inferior retina, and autofluorescence imaging will be showing decreased area of the retina, and FFA will show delayed arterial filling. These are the common signs that you can see. Now coming to the management. In case of management, what you can see here is aggressive treatment is required for the acute episode of central retinal artery occlusion. So, aggressive treatment is what we are talking about now. What is this aggressive treatment? The first thing is to lower the intraocular pressure. Immediate lowering of intraocular pressure is required. This can be done by intermittent ocular massage, intravenous mannitol, paracentesis of anterior chamber, and intravenous acetazolamide 500 mg. So, the first thing that we have to do is decrease the intraocular pressure. So, that can be done by doing small massage over the area of the eye, that is intermittent ocular massage. Then intravenous mannitol, it is an osmotic diuretic, it helps in reducing the intraocular pressure. Paracentesis of the anterior chamber is very much useful, and intravenous acetazolamide 500 mg is also preferred. Then inhalation of 5% of carbon dioxide with 95% of O2 is going to help. Vasodilators can be given. Vasodilators generally sublingual or transdermal NTG and oral isosorbide can be given. So, these are the common agents, vasodilators, isosorbide dinitrate, and retrobulbar acetylcholine is also good in case of vasodilators. So, vasodilators you can give nitroglycerin as sublingual as well as transdermal route, and oral isosorbide dinitrate, retrobulbar acetylcholine can be given as vasodilators. Now, fibrinolytic therapy can also be taken into consideration because of most of the times it is an atheromatous or a platelet fibrin kind of emboli. So, fibrinolytic therapy is also considered. Steroids, intravenous steroids is considered only if there is a component of giant cell arteritis, and laser photo disruption can also be done as aggressive treatment in case of acute episodes. Now, always do workup for the associated conditions, like most of the times it is a cardiac emboli or a coronary artery problems or a carotid artery problems. So, what happens here is a Doppler or a echo will be very much essential to identify other problems, that is associated conditions which has led to a central retinal artery occlusion. So, we were discussing about blood vessel problems, that is artery occlusion of the central retinal artery. Here etiology we discussed, the major clinical features, the signs is very important, the cherry red spot, the cattle trucking, the OCT, autofluorescence as well as FFA finding. And then management, aggressive treatment including the drugs that will reduce the intraocular pressure with ocular massage, inhalation of 5% carbon dioxide with 95% O2, vasodilators, fibrinolytic therapy, steroids and laser photo disruption. So, workup for any associated conditions is also important in the last area of central retinal artery occlusion. Now, coming to the next one, which is central retinal vein occlusion. So, when artery gets occluded, we know how it happens, what is happening and what are the clinical features and what are the signs that you can see, all those things, including the treatment. Now, in case of central retinal vein occlusion, again the etiology is important here. Here basically it is due to a thrombus formation. A thrombus is formed there. Now, how this happens is because there is an atherosclerosis involving the retinal artery. So, atherosclerotic retinal artery is there. In that case, when these artery and vein, they share a common adventitia. So, because of this, there exerts a pressure on the vein when there is atherosclerotic changes in the artery. So, when there is atherosclerotic changes in the artery, this will in turn lead to a pressure exertion on the vein, and because of this there is thrombosis being induced in the vein. So, that is the main reason or etiology behind a central retinal vein occlusion. A thrombus formation is the main reason. An atherosclerotic artery, retinal artery exerts a pressure on the vein inducing a thrombosis in the vein. But always remember, there are certain predisposing factors to this condition. Why this thrombosis occurs is because of certain predisposing factors like age being more than 50 years. So, age more than 50 years, individuals who has an age of more than 50 years are very prone to develop central retinal vein occlusion. A patient who has comorbidities like hypertension, diabetes mellitus and any other conditions where the hyperviscosity of blood is present. The blood is really viscous, that is polycythemia or hyperlipidemia. All these conditions are associated with the risk of developing central retinal vein occlusion. So, hypertension, diabetes mellitus, conditions like polycythemia, hyperlipidemia where the viscosity of the blood is high. And then there comes periphlebitis retinae. This is usually seen in conditions like sarcoidosis, systemic lupus erythematosus, syphilis, etc. So, basically it is an inflammation of the veins of the retina. Now, another important thing is same as that of the arterial occlusion where there is a raise in the intraocular pressure. Most commonly primary open angle glaucoma is what we are talking about. Then the use of OCPs, any smoking history and certain local causes like those causes around the eye, that is orbital cellulitis, orbital tumors, facial erysipelas, cavernous sinus thrombosis are the common examples. So, predisposing factors starts from age of more than 50 years, hypertension, diabetes mellitus, hyperviscosity of the blood, basically polycythemia, hyperlipidemia, periphlebitis retinae where sarcoidosis, SLE, syphilis are common causes, raised intraocular pressure, commonly primary open angle glaucoma is the one, and OCPs use, smoking as well as local causes, that is around the eyes like orbital tumors, orbital cellulitis, facial erysipelas, cavernous sinus thrombosis. All these are certain risk factors where the vein can go for occlusion, the central retinal vein. Now coming to the types. So, based on the presentation, there are three different types of central retinal vein occlusion. The first one is an impending occlusion. The second one is a non-ischemic occlusion. Basically, this is due to venous stasis. There is stasis of blood flow in the vein. That is the main reason. And ischemic central retinal vein occlusion, most of the times it is hemorrhagic in origin. We will discuss each one under the clinical features and the treatment. So, the first one is an impending central retinal vein occlusion. So, here it is more common in a younger age group compared to that of the adults. The common symptoms are the same. There is mild blurring of vision and it is more in the wake up time. So, as soon as the patient wakes up from sleep, it is more, and as the time progresses, the pain, the vision, the blurring of the vision improves. So, mild blurring of the vision is the main complaint in case of an impending central retinal vein occlusion. Now, what are the signs? So, there is venous dilatation, the retinal venous dilatation will be present and they will be very much tortuous also, and but remember it is very mild in this case, this impending retinal vein occlusion, it is mild, retinal venous dilatation or tortuosity, it is all mild. And you can see few scattered small flame shaped hemorrhages. So, flame shaped hemorrhages can be seen here and there scattered in the examination, and mild macular edema. So, all these things are present but in a milder form. So, mild retinal venous dilatation with tortuosity, few scattered small flame shaped hemorrhages, mild macular edema. These are the common findings in case of an impending central retinal vein occlusion. Now, coming to the common investigations, you can see here that OCT, FFA and FAF can be done. So, under OCT, you can see that mild macular edema will be present and the retinal circulation time is increased in case of fundus fluorescein angiography, and autofluorescence will show fern-like perivenular appearance. Around the vein, you can see fern-like appearance in autofluorescence. So, optical coherence tomography will show mild macular edema. FFA, fundus fluorescein angiography will show increased retinal circulation time. The circulation time is more in case of central retinal vein occlusion, and autofluorescence is going to show fern-like appearance around the veins, perivenular fern-like appearance. Now, the treatment is very easy. Correction of the predisposing factors. Whatever is the predisposing factor which I already mentioned is existing in that patient, that should be corrected. The second thing is to avoid dehydration. If there is increased intraocular pressure, lower the intraocular pressure, anticoagulant or antiplatelet therapy can be started as required by the patient. So, these are the major things that comes under impending central retinal vein occlusion. So, usually seen in young patients than that of adults. Mild blurring of vision is the main complaint, which is more in the wake up time, and over the time it reduces or improves. Signs are mild retinal venous dilatation or tortuosity, mild macular edema, few scattered small flame-shaped hemorrhages can be seen. Investigations, OCT will show mild macular edema, FFA shows increased retinal circulation time, and autofluorescence is going to show fern-like perivenular appearance. Treatment is correction of the predisposing factor and other corrections like lowering the intraocular pressure, avoiding dehydration, anticoagulant and antiplatelet therapy. So this is what